Good morning and welcome to the Oregon Health Policy Board meeting. We'll give board members a few moments to join us and welcome everyone to the time together today. Good morning. As people are warming up, I'd like to go ahead and cover a few housekeeping things. So my name is Brenda Johnson. I have the honor and privilege of chairing the Oregon Health Policy Board. I use she, her as my pronouns, and today I will start off on the agenda with some housekeeping. So the Zoom feature in today's meeting only allows meeting attendees to message the host and the co-host and no other meeting participants. So any questions, thoughts, or comments can be sent via Zoom chat to the meeting host. If you have a supporting resource link to share with meeting participants regarding anything that is on the agenda or anything currently being discussed, go ahead and share that link with the meeting host, which is Tara, and she'll be able to send it out to everyone else. And thanks, Tara, for putting that in the chat. All materials for today's meeting are available on the Oregon Health Policy Board website and are also hyperlinked to today's agenda. Tara always supports us by offering up a roll call, so we'll go ahead and do that next, Tara.
Great. Thanks for that, Brenda. Start with Brenda Johnson, Kristen Isaacson,
Present.
Tony German,
Present.
Melina Moran, Bill Kramer,
Present.
Dr. Rosemary Hemmings,
Present.
Carly Hood-Ronick,
Present.
Peter Starkey.
Present.
Great. We have 7 of 8 members present for quorum, and I will connect with Melina, make sure she's logging in.
Great, thank you, Tara. Next up on today's conversation is to welcome Dr. Rosemary Hemmings to share our health equity definition, read that out loud and have that inform our focus and our work for today. So Dr. Hemmings, if you don't mind.
Is that going to be shared? I wasn't prepared for that.
Oh, sure. There we go. Thanks, Tara.
In the chat, and for everyone following along, it's on page 2 of today's agenda.
OHA and OHPB health equity definition. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among those communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices.
Thank you, Dr. Hemmings. Next up is to do a quick review of our agenda for today. So you've all got that, and again in our meeting materials. Thanks, Tara, for posting it in the chat as well. We'll start off with some board business, approval of our meetings, got some topics on our liaison role, some additional content for us, and certainly a conversation about our board's business. We'll then work through a presentation, and thank you very much for those who are supporting this work of us understanding a little bit more about OHA's strategic planning process and timelines. We'll then invite a presentation for our 11:15 waiver updates and take a break. After that break, we'll entertain some public comment, always a really important part of our work together. We'll also have an update on the Cost Growth Target Advisory Committee, and they have for us today a proposed action on a membership slate adjustment or addition. And then we'll pick up our conversation in support of the Coordinated Care Organization Quality Incentive Metrics Program, and that'll be introduced by Kirsten and supported by OHA staff as well. And so you've got materials in that in our agenda to review if you haven't done so already. Okay. So I'll just move us, I think, right next into our board business. So first, again, to welcome both Carly and Peter, who have officially joined our board. Welcome. We had a great opportunity to have a welcoming conversation and hosting an informal gathering to get to know one another last week, which was delightful. So I really appreciate board members' time and attention in that gathering as well. We have done some incredible work, I think, in our assignment of liaisons, and I've asked Kirsten to go ahead and prepare our board, maybe talk a little bit about the liaison modeling, some adjustments that we've made, and some consideration for us as board members. So I'll just turn to Kirsten now for that. Thank you.
Yeah, thanks so much, Brenda. Good morning, everyone. Yeah, so we do, I'll just first call out in the board packet that we received, there is number 1.0 is the liaison assignments and role. And I don't think anything on there, any of the assignments are a surprise or have changed since we last spoke about them. But I just wanted to highlight because so many of us are new to the board, and this is we have shifting liaison assignments here. That this happens, especially when we have new board members join OHPB. The chair reviews and sometimes reassigns liaison positions. I have been the liaison to three different committees my time on the board, and actually switching it up is really invigorating and healthy, I think, for the work of the board and the work of the committees. And as we know and will know and are reminded to appreciate often, there's a substantial amount of work that happens at the committee level. And the way that each committee is structured and functions can be quite unique. So, you know, health equity was created by the board. Many others were created in statute. Their members are very specifically identified in statute. Others have a lot more freedom. And so they really vary, but the unifying thread through all of them is that they carry an important portfolio of work. And so our role as liaisons, regardless of which committee we are liaisoning with, is to listen and to support and kind of influence that committee occasionally so that all of us, the committees, OHPB, are working in a coordinated fashion. We wouldn't want there to be way different targets because we are all supposed to be working towards the same goals. And so just wanted to highlight that while we sit at these committee tables and we participate in committee meetings, we don't vote for that reason. We get to vote and have our more decision authority here in an OHPB setting. And and when we're at committee meetings, we are there to listen. We are also, really importantly, a conduit of communication. And that communication is to the committee about relevant topics at the board level. And while you're at the board, it's communicating back to this bigger picture of the needs, concerns, activities of the committee, and including introducing committee work to the health policy board for guidance or vote. So our new two-person structure is a little different. So this will be an interesting experiment and learning opportunity for us. And I just wanted to highlight that I think we should allow that two-person structure to be as unique as the committees are themselves. So these duos that we have can really look like a co-liaison. They can look like backup when someone can't come. They could look like an incoming and outgoing liaison and a passing of the baton. So, but the goal of having these two liaison assignments is to create, continuity and coverage, to foster relationships among ourselves, among board members, and to really broaden our understanding of the topics and the committees and the work of the board. But I do want to make really clear that the goal is to not double the board's influence over these committees. And so when we have our 2 liaison structure, we should be thoughtful about the size of these committees and how the presence of more than 1 liaison might alter the committee's meeting and dynamics. But so with that kind of freedom and flexibility about what the 2 liaisons role might look like for each committee, would like to ask each pair of liaisons to kind of figure out over the next month to connect and discuss for the committee that you're both assigned to, kind of what the appropriate relationship or situation will be for that committee that you're serving, and then communicate that back to committee staff and chairs by the end of the month, so that staff can do appropriate onboarding of 1 or more liaison people, which is a substantial amount of work. So we just want to be thoughtful about what is being asked there and communicate what's needed. And there's a great, like the attachment in the board 1.0 packet about liaisons. The first page is the roles or the assignments. The second page really is in writing, kind of what a liaison does and some guidance for that. So feel free to use that as a reference point at any time. And of course, open to questions. Any thoughts or concerns? Dr. Hemmings.
Yes, good morning. I have to say that I appreciated the information in the packet as someone who's new to the board. And even though I've been on some of these committees, this will be my first time being a liaison as it relates to OHPB. So I just want to say thank you for putting this together, because it's really helpful for me to understand the role. So I appreciate that.
Got it. And liaisons haven't always existed for the board. And so I would encourage all of us as we go through this to like say what's needed, make adjustments and improvements. So glad to hear it's useful. And let's keep making those improvements. So.
And I just have one more, more of a question, and I'm assuming the answer is yes, but I just wanted to find out because I noticed that the Health Equity Committee meets the 2nd Thursday of the month. And I haven't received any emails or anything from them about the link for that meeting. So I was just wondering, how is that communicated with the committees in terms of who the liaison is? I'm not the primary, but how does that information get communicated so that we get the links to these meetings?
Yeah, Tara, go ahead.
And all board members, we will be introducing you via email to the committee lead staff person that will be forwarding you the meeting series appointments for the committees, as well as doing your onboarding. So I know some of you have already reached out, but for all of those who have not yet, I'll send introduction emails today.
Thank you.
Thank you, Kristen. Are there any other questions or comments? Okay. I also appreciate the body of work connected to this. So thank you very much for helping support that, each of you. All right, next up, would love to talk about the Oregon Health Plan or Policy Board Work Plan and the calendar that is also attached to your material. So by way of background, this body of work and the document that you have before you has been in process for quite some time. It also has a little bit of a roadway to go before we feel confident that we've completed the tasks at hand. And also consider this document to be something that's somewhat fluid on the edges as the needs of the Oregon Health Authority change over time, as the board's areas of interest, while staying focused on the priorities that's on our work plan. We also recognize there's certain things that the agency and the state wants us to address from time to time that may not be reflected on this work plan or on this calendar. So far, what we've done, there have been a lot of conversations internally with the leadership staff support to the board. The board, Kirsten and myself have had a lot of input in this document, and we've asked you as board members to consider if we're on path and if these are specifically the areas of intention that you think should be our focus for this next year. While we're right now in the process of gaining board committee inclusion and involvement, additional OHA leadership involvement, and specifically looking forward to Dr. Hathi's and the Governor Office inclusion on the priorities and on the work plan itself, and most specifically to ensure that the alignment of the board's work is in step with what the agency's planning process looks like, so that it's really kind of hand in hand with one another about where we're really harnessing our collective energy. So as a reminder, Kirsten and I meet with the Governor's Office and OHA leadership, and we're working on calibrating the frequency of those meetings right now. But that's a really important opportunity for us to ensure that we're all kind of staying on track with one another and really kind of pacing, not leading or pacing, inappropriately in any specific way with one another. So this is mostly just to remind you that those meetings are happening. And if you as board members want to know more information, you can contact Kirsten or I, or if you have specific areas of interest that you want to make sure get included in those meetings, you're welcome to join them as well. The other piece in terms of board business, well, let me pause there and see if you have any current reflections on the calendar, the process of developing the calendar itself, or kind of where we stand in its development. Anything that comes up for any of you. Okay. It's okay, stay tuned because this is our, yes, please, Kirsten.
Sorry to put staff on the spot. I was just wondering especially for the travel meetings, for the community meetings, about how far in advance do you usually aim to set the location?
We're happy. We'd like to get that set now. I think a part of that will be input from board leadership and board members on if there's a specific connection to a community where there is a priority area conversation that you want to have, or there's a specific conversation or population that you'd like to hear from that aligns with our work and our priorities. We would try to do that, but if we're just trying to be supportive of the statutory requirements to meet in all congressional districts, we can just start moving around the state, but we would like that to be a little bit more thoughtful and strategic. So if board members have preference or suggestions on the locations we go to first, we certainly welcome that. But ideally, we should get those locations set at least tentatively in the next month, so you all have time for scheduling.
Go ahead, Tony. Tony, I'm having a hard time hearing you. No luck yet. While you're troubleshooting, I'd like to share a few more things on the meeting location, specifically around hybrid and in-person meetings. Our next one is scheduled for June. And this is also the meeting, if you just call your attention to the calendar, where we'll dedicate the majority of that time to exploring the cost growth target program's public hearings. So have a bit of a blended time together. The other piece to Kirsten's point, and Tony, I'll come back to you in a second here, but in terms of anticipated travel schedule, Tara also highlighted for us the reference that in 2025, we'll have probably much more of a traveling agenda, mostly as we think about our community engagement responsibilities, not only in CCO procurement, but also as we think about, as of course, to hit all four corners, so to speak, of the state itself. So we'll anticipate what that'll look like moving forward as well. Tony, let's test your audio and see if we've got you back. Oh, it doesn't look like it. Go ahead, Tara.
He might have just called in, but I saw him.
I'm sorry, Tara. I'm also having a hard time hearing you.
Oh, I think Tony was just logging in again by phone.
Oh, okay, great. Great. We'll welcome him back when he joins us. Okay. So thank you, Tara, for the chat. She also references for us in the last page of our work plan, and in the calendar itself, we'll see the monthly meeting dates, the format and location. We did hear from one of our new board members, Peter, thank you for the feedback, a question about should we have, more consistent hybrid meetings? And I definitely want to take that back to our leadership meetings on Tuesdays and talk with Tara and the staff about the logistics of what that might look like. So appreciate that kind of feedback always from board members. Keep it coming. Okay. The other piece by way of board business, just a quick reminder to board members that Kirsten and I and OHA staff meet every Tuesday morning for weekly planning meetings. Often that meeting focuses on the alignment, as we're talking about, for the calendar itself and anticipating work yet to come, and threading those presentations and the requests that we have for OHPB. You are all welcome to attend those meetings. And with a caveat that as long as we don't reach quorum. So if we're all attending all at the same time, it is a public meeting and we'd reorganize ourselves to ensure that we do that appropriately. However, if there's ever an interest that you'd like, I'm all about inclusion. So if there's ever something you'd like to ensure that we, the board, talk about and you want to have that in a more informal setting or an informal conversation, please don't hesitate to contact Tara or I, and we can make way for that to come online as well. Okay. Next, I would say we have and intend to hold our Oregon Health Plan annual retreat during the October board meeting. We ask that you all hold a full day for that retreat. We'll give you more information, and appreciate your feedback in terms of other community meetings that usually align either before or after the retreat agenda itself. So in the meantime, please mark your calendars. We'd love to have that one for sure in person, and are aiming to get some additional or to get facilitation support for that time as well. Let's see. Next on my list is to talk about the Health Equity Committee educational webinars. There are two offerings that they have generously offered to host for us, March 19th and March 21st. Each webinar will contain the same content, so members don't need to attend both, but you're certainly welcome to if you'd like to. They will also be recorded, so if you're unable to attend either, you'll have the ability to read and watch, or rather watch those presentations and that conversation. This focus is to really help us understand how we learn about health equity overall, how it's evolved with the Oregon Health Authority and within the Health Equity Committee over time. We'll talk about the important role that the Health Equity Committee provides the Oregon Health Policy Board, and learn a lot about the early thinking, the really important body of work that has happened around the strategic planning process that committee has been going through, and that they will plan to prepare for us as part of our April board agenda. So this is your opportunity to ask really thoughtful questions and really engage the content, understand the context and history of what we'll be addressing in our April meeting. Okay, let's see. Tara, did Tony join us back, or are we still working with his question before I move on?
Yes.
I apologize for that delay, guys. Can you hear me?
Yes, I can. Thank you, Tony. Welcome back.
We're just going to pull an audible and do it on the phone here. I'm going to keep my video off, though. I was just commenting. I really appreciate anticipating those meetings as far as travel, setting schedules and things like that. Just one comment, there's a lot of things that are occurring in the Corvallis area. And it'd be interesting to pay attention to the landscape of healthcare in that area, and maybe just an idea for a meeting.
Oh, thank you, Jenny. Thank you so much. Great. Okay, last piece, and certainly not the least, as I mentioned at the beginning, we held a welcome opportunity for both Carly and Peter to join the board, welcoming them again and offering an opportunity. If either of you would like to say more about your introduction to the group, you're welcome to do so now. Is there anything else you want to say?
I don't have anything specific to share other than I was grateful to have the opportunity to join the last meeting and introduce myself and a bit more about my background, which I'm sure you'll hear more about as I ask lots of questions. But I'm very eager to be here and really grateful for the opportunity to work with staff and each of you to move health and equity forward in the state.
Great, thank you, Carly.
I'm just going to echo everything that Carly said because it was just so well said.
Wonderful. We're so grateful that you're both here as well and really appreciate your unique perspective and individual background and expertise to bring to the board and our committees. So thank you so much. All right, last piece of board business is to approve our February meeting minutes. Had an opportunity to review them. I'd entertain a motion for approval.
This is Melina Moran. I'll put forth a motion to approve.
Thank you, Melina. Is there a second?
I'll second. Kirsten.
Thanks, Kirsten. It's been moved and seconded. Any other discussion about the board minutes? Okay. All those in favor signify by saying aye.
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 Any opposed? Any abstentions? Okay, motion.
I think
Thank
both
you.
Carly and I were going to abstain.
Perfect. Well done. Thank you, Carly and Peter. All right, duly noted. And the motion is approved. So next up on our agenda, we have the great opportunity of welcoming Dr. Huffey and also Christine Ernest from the Oregon Health Authority and the Strategic Planning Team lead. Dr. Huffey was really generous in offering this opportunity for us at our first meeting to get to know you a little bit more and then to hear so much about all the deep work that's really happening within the agency to set alignment on strategy. So I'll turn it to you and have you sort of walk us through what you think is important for us to pay attention to today. Thank you.
Awesome. Thank you, Brenda, and really great to see all of you today. We are excited to share a bit more about our strategic planning process, which is a process that commenced many months ago and has accelerated in recent weeks with the intent of meeting a June 2024 deadline set by our governor for a 3-year strategic plan. We've chosen to focus the strategic plan on our 2030 goal and better characterizing and materializing that 2030 goal to eliminate health inequities. And to share more about that process and that thinking, I'm going to invite my brilliant colleague, Christine Ernest, who's also on video here, to walk you through some slides.
Thank you, Sejal, for the introduction, and thank you for having me here today. Wonderful. So I'm going to share with you today some context on how we are moving through our strategic planning process. I'm very excited to be doing this work as we are building OHA's first strategic plan. Can we go to the next slide, please? As Dr. Hathi mentioned, a timeline to complete our strategic plan by June 1st of 2024. The governor has asked us to make sure that we are tying at least one of our goals to diversity, equity, and inclusion and one to the tribes. We have decided to focus our strategic plan on our 2030 goal to eliminate health inequities. And so that focus on equity is built into all of the work of our strategic plan and will be reflected throughout it. As we've been going through this process, We have decided to center the work that we're doing on input we've received from our community and partners over the past few years, and to build that plan off of the feedback we have received. We've heard repeatedly that we have been given feedback, and we are looking to create specific goals and action to implement some of that feedback as we are moving forward. We're simultaneously building what we're calling a track 2 approach to strategic planning, which is about building long-term capacity for meaningful engagement that will inform our ongoing strategic planning with our health equity definition. We'll talk more about that track 2 plan as we move through. Next slide, please. This is to give you a high-level view of the work that we have been doing and are focused on over the next few months as we move towards June, the June deadline. The work is centered in our mission, vision, values, the 2030 goal to eliminate health inequities, and the health equity definition. Over the past few months, we've been building our SWOT analysis and our PESTLE analysis. Both of these are scans of the environment. The SWOT is a strengths, weaknesses, opportunities, and threats scan that focuses on the Oregon Health Authority and our work toward our 2030 goal. And the PESTLE analysis is a political, environmental, social, technological, legal, and economic scan that focuses on the broader environment within which we're currently working. From there, we're building goals, strategies, and measures to focus our work from 2024 to 2027. Each of those then will have plans specifically focused on how we will resource and move forward in that action. And then we will be putting that all together and creating a strategic plan that we can share and monitor over time. Next slide, please. I wanted to give you a quick view of where we're at in the process. We have completed a number of the required components of the strategic plan. We're actively working on the goals, outcomes, and strategies at this point, and looking to build the action plan, resource plan, and monitoring and evaluation plans over the next few months. Next slide, please. Okay, so I wanted to share with you how we are approaching the decision-making and the process for the work that we're doing in the strategic plan. The sponsor committee is the primary decision maker for the work that we are doing in the strategic plan and making those decisions about what will be included. Those decisions are based upon the input and the agreement of a number of other groups that we have in the organization. The core project team is supporting the development of this work. We're engaging subject matter expert teams and a broader group of OHA professionals in the strategic planning group that are informing the decisions and recommendations for what is included in the plan. Next slide, please. All right, so here I'd like to situate you briefly. In the process, we have been working through to get to the point we are today in our strategic plan. This work started at OHA quite a while ago. In 2018, 2019, OHA began the process of defining our mission, our vision, our values, and the performance management system that allows us to view and respond to the work taking place across the agency. That is the foundation upon which we are moving forward. The next you see there in October of 2019, we adopted the health equity definition. Carly, I understand that you were co-chair of the health equity committee when that health equity definition was defined, and OHA has adopted that, and that is foundational to all of the work we're doing as we're moving forward. In 2019, OHA embarked on some very intentional engagement with community to inform our strategic planning work. That feedback led to the development of our OHA strategic goal to eliminate health inequities in Oregon, with the understanding that when we say eliminate health inequities in Oregon, we are working towards that health equity definition. Since 2020, the world has changed pretty dramatically, and we have continued to work with community in a number of different environments. And we received feedback throughout those years that we are incorporating into our planning process here and now in 2024, along with the feedback we had received in 2019. Next slide, please. Excuse me. So I wanted to take a moment and touch a little bit more deeply onto our approach for engagement. So in 2019, we had intentional engagement that was designed specifically to inform what our strategic goal and our strategic plan should be considering. The results of that were the development of our 2030 goal to eliminate health inequities in Oregon. Since that time in 2019 to 2030, as we responded to the pandemic, the wildfires, and a number of other work taking place across the state, we continued to receive feedback from community and from partners. And that feedback we have decided to center in the decision-making process as we're moving through this strategic plan. As we're building the plan, we are looking to this year close that engagement loop with the communities who shared feedback with us that are informing our planning process at this point. And then finally, the step of our track 2 work, where we'll be building an agency-wide framework for ongoing community engagement that can inform ongoing strategic planning for the work that we're doing. Next slide, please. I want to take a moment and give you an opportunity to quickly view the visual here that represents how all of the components of the foundations of our work are coming together to move us towards our vision of a healthy Oregon, with the strategic goal, our key goals, our mission, our values, all moving in the same direction. Next slide, please. Our strategic goal to eliminate health inequities in Oregon by 2030 is the foundation for this work. It is the center and what we are working toward with each of the goal areas that we are focused on developing in this strategic plan. Next slide, please. And we are focused on eliminating these health inequities. I'm not going to read the health equity definition to you again. I appreciate that that was shared at the beginning of this meeting to center and ground everyone. And it continues to center and ground OHA as we're doing this work. Next slide, please. We have identified 5 goal areas that will be developing the goals, outcomes, and strategies and plans that will be moving us toward our health equity goal. The first one, to improve access to affordable healthcare for all. The second, to transform our behavioral health system to ensure that it meets people where they are. The third is to foster environments that keep people healthy and equitably promote well-being, especially in communities that have been socially and economically marginalized. Build the infrastructure internally necessary to eliminate health inequities and model an anti-racist workplace is our fourth. And the fifth is a goal focused on the tribes, and this goal will be developed in partnership with the 9 federally recognized tribes in Oregon per our OHA tribal consultation policy and process. Each of these goals will have these strategies and outcomes that will move us forward. And we are focused on building SMARTY goals for each of these so that it is clear, time-bound, achievable, measurable, inclusive, and equitable. Next slide, please. All right, so that gives you a quick overview of how we're approaching our strategic plan. And as we are here today, I'd like to take an opportunity to get some input from the board on these 3 questions here. So I will pause, and also Dr. Huffey, if you'd like to share anything for a quick moment, give you that space.
Okay. Thank you so much, Christina. What an incredible body of work. And I really appreciate the opportunity to ask the board members about their feedback, and these questions serve as a really useful prompt for us. So let's just take them one by one. What else should we be considering as we hone these 5 goal areas and identify measurable strategies and actions to achieve them? And perhaps we could look at the 5 goals again, if you don't mind flipping back a slide, Tara, there we go, thank you. So what supports us in achieving these 5 goals, or if you have any specific questions about any of them? Yes, Dr. Hemmings.
Thank you for that presentation. I had a question, but I'm going to try to roll it into number 4. Build the infrastructure internally necessary to eliminate health inequities and model an anti-racist workplace. And my my question was related to the PESTLE analysis, which focuses more so on the larger environment and political environment. And my question was going to be, I noticed that the strategic plan is from 2024 to 2027. And, there is a lot happening in the political realm, which I was just wondering whether or not there is going to be some allowances to make adjustments to the plan as we continue to see changes within the political landscape, which will definitely have an impact in the state of Oregon. And, as I look at number 4, I'm specifically looking at how I guess I'm kind of suggesting or recommending that there be some considerations that the impact of our political climate as it changes between now and 2027, that number 4 I would hope remains a goal, but that there is some understanding that there may be additional pressures around this which might impact achieving that goal in a negative way. And I just wanted to do considerations around that. And my other question was, in the SWOT analysis, I was curious because it's looking at analysis of current state, and I was just curious to know, and I guess this would apply to all 4 of the goals in terms of a baseline, what metrics or what data was being collected to do that analysis. I hope that made sense.
I appreciate your questions. Thank you. Yes, the questions absolutely did make sense. And so taking them one at a time, I appreciate the recommendation to consider the impact of changes that may occur over the next few years. The strategic plan is designed to create goals for 2024 to 2027, and our monitoring and evaluation plans are intended to be designed so that we are able to assess the progress, assess the needs, and adapt as we move through. So I will take your note, your comment, and your recommendation to that process and appreciate that. For the SWOT analysis, that SWOT analysis was done by asking our teams to identify the strengths, weaknesses, opportunities, and threats that we are currently facing. That was not a heavily data-driven process itself to do that scan. And OHA regularly monitors outcomes in all of the work that we are doing. And that is part of the performance management system that we use to review those outcome measures. And those reviews are our ongoing process within the agency. So I will pause there in case Dr. Hathi would like to add anything additional to that.
Thanks, Christine. Just on the SWOT on the pestle analysis. So I don't know if folks here are familiar with a pestle analysis, really knows what that means. So just briefly, SWOT is pretty self-explanatory: strengths, weaknesses, opportunities, and threats. A pestle analysis is similarly a tool to understand, ascertain, and synthesize the perspectives of a broad swathe of people, typically on the political, economical, sociological, technological, legal, and environmental attributes, qualities, and other ongoing developments externally and internally that could impinge upon and otherwise affect the progress of an organization in achieving its strategic plan. And so typically how these have been done has not been, I've done a number of these over the years. They're not super data driven, I think, in the way Dr. Hemmings is suggesting, but teams are bringing to each of these exercises their own experiences, their subject matter expertise, the data that they themselves have about the success and efficacy of their programs, and using that to inform their perspective and analyses of each of these factors. And so because this is such a broad exercise, it's done with staff across the agency. We hope that the information that we are receiving, which again is just one facet of what has been many years of fact-finding and engagement in and around the agency, is additive to the broader analysis we're doing about what the most important goals, strategies, and actions are. That's all I would add. Carly?
Yeah, thank you, Dr. Hathi, and Christine for sharing. It's wonderful to see kind of where things have been as a newer member to the board and the projection for the next few months. As I look at the goal areas, they still are quite broad. I think that's an area that obviously in the next few months you will be digging into, but I guess I would encourage and kind of question, how focused are we as a state in being able to get down to the root cause of what is driving poor health across communities. So for example, goal area 3, foster environments that keep people healthy. That could be a variety of different things, right? We could look into housing, we could look into walkable living environments, access to childcare. So I think really getting specific around what are the areas that are going to have the greatest impact will be super, super important, just given how broad the goal areas are at this point in time. And I wonder if you have any thoughts about that, about that feels like a very difficult task to get down from an overarching goal down to something that really helps us all understand what we're focusing on. It's totally okay if you're not there yet, but I'm just curious if any of that resonates or if you have thoughts on that.
Absolutely.
You want to take that first, and then I can add on as needed.
Beautiful, thank you. So our process of working from the goal areas to the SMARTY goals is designed to help to ask very specific questions that help create focus, that will make sure that the goals we are ultimately selecting are focused and achievable within a 3-year time frame, really trying to get at the root of some key actions that can be taken over the next few years that will move us towards these broader goal areas. And I will pass it to Dr. Sejal-Hathi to add to that.
Sure. So these goal areas are really what they sound like. They're just broad categorical areas under which SMARTY goals are intended to fall. And so we set those goal areas to begin to scope the types of SMARTY goals, which are SMART, measurable, actionable, equitable, inclusive, et cetera, goals that subject matter expert teams in consultation with our agency-wide strategic planning group could subsequently devise. And so currently we are reviewing draft SMARTY goals that team has assembled with the aim of finalizing those in the coming week. Those are a lot more specific. They are, as they sound, again, SMARTY goals, and these goal areas are just the penumbra under which they fall. Tony?
I believe Peter might be at a.
Sorry. Thank you, Peter. Thank you, whoever said that. And go ahead, Peter.
Thank you both. I know that a lot of work has gone into this, and Dr. Hathi, I think back to just kind of when you first came on, it resonated with me. You were talking about Oregon as a leader, as an innovator, and then in sort of thinking about SWAT and PESTEL and thinking about the threats in the political environment. Just one thing that I hope is included, not necessarily as like a top 5, but somewhere in here, is the preservation of rights, healthcare rights that are in our country being eroded. And just ensuring that we as a state are being a leader in that preservation of right and enshrining that right, because I think that the rights that are being taken away directly correlates and is a causation for health inequity. So just wanted to add that thought.
Thanks, Peter. We'll add that, and maybe Christine, I see her writing something down. We'll add that to the list if it's not already on there. Thank you. Now, Tony, I think.
Thank you, Dr. Hathi. Well, what remarkable work, and thank you, Ms. Ernst, for coming in, and I really appreciate Dr. Hathi. I know we put you on the spot last meeting and talking about these strategic plans, and this is really lovely to see in front of us, the construct of, a pathway forward and using tools that have been effective strategies to look and get to those finer details that I think Carly and all of us are very interested in seeing. I did want to call out number 1 in the goal area, and it strikes me as interesting, the word improve when we're saying eliminate. And I know that in this country, we still struggle to get to completely affordable care. But, as far as number 1 being achieve access to affordable health care for all is something that I still struggle with, and why I am interested in being part of this board. There are some tools that I think that maybe in our questions below the Q&A, I'd be curious to fellow members on OHPB of how alignment between OHPB and OHA in thinking of, legislative, we've passed some processes as far as 1089 over the last couple of years in the governance board. And I do think that there's something for us to think about that I think as I've come to be on this board just a few short months is the highlights of which OHPB is to really be able to share information with the community of Oregon and what work and what investigative work and what expert analysis is going to take place for us to reach universal health care. And I would just pause for us to think about, is on our agenda as we're thinking about this calendar over this next year, is there value in us being connected with that? I know it's just getting off the ground, but I really do think that there is a good body of work that is going to take place. It has been an ongoing process, but I think that we have a lot to learn, and with which the state of Oregon can learn from as well. So it's a question and a comment related to that. I think that the governance board be something that I think as the OHPB we should be paying attention to and highlighting where there are struggles and where there are successes in that work.
Thanks, Tony. Appreciate the comment and also the desire for ambition and boldness and devising every one of these goals. And I think more importantly, the specific actions we take to achieve those goals. And we will certainly keep that in mind. And I look forward to working with this board in identifying those policies, programs, other strategies we may consider, adopt, and scale to expand access and otherwise achieve access to affordable healthcare for all. So really looking forward to working with this board as a thought partner in that mission. Brenda.
Thank you. I wonder if we can spend a little time on the Track 2 community engagement framework, and first start by deeply, deeply appreciating, Sejal, your work in doing listening and community exploration across the state. I know here in Southern Oregon, your visit was really warmly received, and I think it's a testament to how community engagement can really work. So if we could spend a little moment to talk on that second question about what does this Track 2 look like? Is it significantly different than the other types of community engagement funnels that you attract, or how are you envisioning that process moving forward?
Christina, are you going to take that?
Sure, I will. I will do that. Thank you. So as we're thinking about Track 2, what we're looking to do is build upon the successful engagement that we currently have occurring in the agency. And at this point in time, what we're looking to do is create the infrastructure and the support so this engagement is an agency-wide effort and a cohesive effort across the agency. And this Track 2 work is being designed by the experts we have internally in our community engagement process.
Do you want to offer, Christina, I know that, Track 2 is a longer term effort, so I'll just say that as well, but it's work that we consider continuing and evolving after the publication of this initial strategic plan in June. And I think happy to discuss that more at a later time, Brenda, or in a smaller group as we design what that looks like.
Thank you. Other questions? Yes, please, Kirsten.
So much, I mean, I get it's not so much a question, but to this question about what do you consider, I did want to just highlight and appreciate the earlier bullet about the intention to circle back on engagement and report back to community about how that input is reflected in the strategic plan. I don't think we can underscore enough how valuable that is. And so kudos for that already being part of this year's work plan. And that's what I would draw forward for Track 2.
Thank you very much. I appreciate the comment and the consideration for our track 2 work that is ongoing.
Thank you. I know that I see Leanne has popped up or on camera. I'm curious, Leanne, I know you've done a lot of work prior to this specific effort. Is there anything else here on community engagement you want to share at this moment?
Good morning. Thank you. I'm Leanne Johnson, Director of the Equity and Inclusion Division for the Oregon Health Authority. And I think Christine and Dr. Hoppy have covered the overview of track 2. And I would add to that track 2 started prior to the strategic planning process and will extend beyond the strategic planning process. And a couple of years ago, we recognized, well, actually we've been recognizing it for some time, but we're able to get traction a couple of years ago around some broader conversations across OHA, because one of the pieces of feedback we're getting from community is the burden of community engagement. And so there would be maybe 3 or 4 different areas of the agency reaching out to the same groups. And from the standpoint of our work is to put community in the center or in the lead, and we follow that. And we were continuing to burden the community in a way that was not conducive to good, strong opportunities for feedback. So we have convened a team that was convened last year that includes 30 people, close to 30 people or more from across the agency, various divisions, and people that where community engagement is either their specific expertise or part of their job. And our goal is really to create a framework for community engagement for the agency where we are connecting and communicating internally so as not to burden and also able to better leverage information that we do receive, and doing that in a way that does not squelch the organic nature of community engagement at the same time. So we're at that fine tension point and balance. So that is the general framework idea of moving that forward and ensuring that first and foremost, we recognize that relationships are really at the heart of community engagement, and that community engagement through relationships happens every day. And we as an agency should not be seeking input on a very specific activity or policy or program over and over again without also recognizing that through relationship, we can have a feedback loop that's occurring on a regular daily basis rather than one that is exploitive or extractive or creates a situation where, once again, we are burdening communities. So we're trying to lift above the dynamics, the current dynamics, and create something that has a framework, communication internally, without, once again, squelching the organic nature that's necessary via relationships. And Oliver Vera, who's the Community Partner Outreach Program Director, and I are serving as the co-sponsors of this work. Thank you.
Thanks, Leanne. The last of the 3 questions that you've posed for us are, where do we see alignment between the Oregon Health Policy Board and OHA's strategic work over the next 2 years? It's such a great question, and I'm curious about board members' reaction to this last one. Where do you see the overlap and alignment? Kristen, please.
I see a lot of overlap and alignment here, and in some ways I'm like, oh, how do we I think there's like chicken egg tension, or I hope there's not, but I would understand if there is, of kind of like who's identifying it, you know, putting the skeleton to the plan or first, but that we're working in coordination. And specifically, I think the 2 things that occurred to me, well, one, that that part of our CCO procurement goals for the board, or our priority, is around kind of engagement. And so I'm like, we need to tap it. How do we follow the best practices here as the board thinks about CCO work, our CCO procurement work? And so would love to follow, yes, in these thoughtful and knowledgeable footsteps. And the second is really like, I'm very excited about that first goal around access to affordable healthcare. I'm excited and intimidated by it, but in all the good ways. And I have been wrestling with like, what does it mean to pursue affordable care in our state? And at the heart of it, it's bold action. And I hope that Oregon will continue to take bold action. And I would like OHPB to be a partner with the health authority in identifying the roadmap of that bold action. And I think, Tony raised kind of the universal care path. I think Oregon has put our chips in the past in kind of a, let's move away from fee for service and go towards value-based payment. I'm curious if we should continue to put our chips on that path or not. And then I think there's growing appetite nationally for just saying like, you know what, cat's out of the bag with consolidation, all these flirting around the edges don't work. You know what we need to do? We need to set and cap prices and just say what they are and make them lower. And so I think there's a wide variety of bold actions that could be taken. And I don't know how we identify which road, which path we want to go. The state of Oregon should go down. And I don't know that that's the health policy board's. I don't believe that should be our decision alone, but I hope that we can be a thought partner and an ally in pursuing that bold work to achieve affordable care in our state. And so I welcome, as we define our relationships here and how this goes forward, I welcome it, and we look forward to being that partner.
Thank you, Kirsten. Christine, go ahead.
I just wanted to say thank you, and I appreciate your comments and your insight and the enthusiasm for partnership.
Thank you. Carly, go ahead.
Yeah, Kirsten, well said. I agree with the notion of trying to determine kind of what bold action we can take. And I think maybe that's what I was trying to express too with the specificity of the broad goals, was how can we get really bold within some of these, not try to boil the ocean, but really pick the few things that are going to impact outcomes and orient ourselves in the same direction. And to that notion, I'm going to crack open, an egg that we're not going to be able to address. But I think, again, within goal 3, sort of thinking about the bigger social and environmental context around everyone in our state, it's not solely up to OHA or OHPB to solve health. There are a variety of other agencies also that ideally have strategic plans that are focused on things that are driving towards what would improve general well-being. So, I hope there's alignment with other agencies as well as strategic plans are being developed to make sure that we're not all working in random pockets and silos to address kind of well-being more holistically.
Thank you, Carly. It leads me to wonder what additional board education may be useful for us, and I'm thinking specifically about the PESL tool. Sejal, if that would be something just in follow-up today's conversation, we could get more information, less about the outcome of the tool itself and more about the process, the discovery, how we might learn more about that mechanism in support of both what Carly and Kirsten are talking about of the legislative, the environmental, context that we're all working and living in.
Happy to send a summary of the types of factors we're including in the pestle. Any other questions?
I'm looking around, I don't see any at this moment. Yes. So I think Sejal just, and Christine, thank you so much for the heavy lifting and the hard work that goes behind this. This timeline is ambitious, and I have known enough to really appreciate the complexity of the agency itself and all of the moving parts of it. It is a fascinating body of work, and deeply appreciate your community involvement, you know, in considering so many voices to listen to deeply in order to make a plan that works for everyone. So thank you both for being here, and we'll move on to our next agenda item, I believe, unless you have any last minute thoughts or reflections, Sejal or Christine, anything else for us?
Thank you so much.
Thank you for the time.
Thank you. We know you're very busy, so really appreciate you being here. Thank you so much. Okay. So next on our board agenda, if we're ready, we're a little ahead of time, which is really great news. We've got a busy board agenda today. So next up is an update from Steph on our Oregon 1115 waiver update. And I'm just checking to see Tara if she's available.
Steph will be here. So I will have her come over, but if I think if we can just pause a minute, that would be great, because I don't see her logged in quite yet.
Great. Well, that's a wonderful opportunity for us to practice good health and well-being. You're welcome to take your videos off camera, and we'll take just an impromptu 5-minute break to stretch, grab some water, and we'll be back in 5. Thank you. Thanks for your impromptu flexibility. We'll come back in one more minute. I think Steph is here for us and just give a shout out to being flexible. So I appreciate that very much, Steph. Okay, welcome back. Let me, it's my privilege and honor to welcome Steph Jerem, who is our Oregon Health Authority 1115 Waiver Policy Director, who's prepared to come and share a bit with us today about the climate benefit that launched on March 1st. So it's some exciting news. And Steph, for those of you who are newer board members, Steph has supported this board for quite some time. It's really great to see your face again. Thanks for coming and being flexible on timing. Go ahead and take it away.
Great. Thank you. Great to see you all. Steph Jerem, she, her pronouns, and yes, I'm currently on rotation full-time as the 1115 Waiver Policy Director. So if we go to the next slide, we are going to talk today about some recent key accomplishments in the waiver space since the last time I was here. I will talk with more specifics around the climate-related services overview that did just launch, and then give some updates on the community capacity building funds. Just a great opportunity to bring it to this board and then folks who are watching today. So if we go to the next slide, we are going to talk about our recent key accomplishments. So one of the things that is really, that's been a learning experience for me, honestly, in terms of some of our waiver processes is that CMS approval is kind of an ongoing thing. So yes, we got approval for the waiver in October of 2022, but then there are these continuous deliverables that kind of keep giving more and more structure to what the waiver actually will look like in Oregon. And at each step, it requires approval and agreement from CMS. And so we go forward again to that slide. Thank you. You'll see that we just received approval of our actual health-related social needs, the HRSN services protocol on February 1st. And so that is the detail of how our waiver will actually play out in the state. We also had other protocols that were approved by CMS. One is related to our community capacity building funds, which I'll talk about. And then also something that's a more technical process by which we claim the actual dollars that we are using to fund the waiver. And then additionally, we had a new initiatives implementation plan that was also approved on the 22nd of February. So lots of things that are still in process. It's been a ton of work from our staff to be able to build towards that. We've been working really closely with our community partners in developing out these protocols to say, here's what this will look like. This is how it interacts with the system. This is how someone becomes eligible. This is the process by which they become eligible. This is our clinical component of this waiver. So happy to share that with anyone who wants to dive into that, but it is what kind of is shaping the rest of the waiver period and also allows us to really kick off this work. The climate specific rules were filed with Secretary of State in January. And then we also had CCO amendments that went forward for the contract to incorporate the climate services. So lots and lots of accomplishments in the past few months that have really allowed us to get to the state. So the next slide, and then we can actually go forward. I'm going to talk about the climate benefit itself. So this launched on March 1st. That was on Friday. Really exciting. We kind of are timing our bigger press for today in alignment with our Health Policy Board discussion right now. So imminently, we'll be getting some press releases out about this. There are 5 devices that are going to be a true benefit. And I know we've talked about this, but these are air conditioners for heat risks, air filtration devices focused on wildfire smoke concerns, Mini fridges for anyone who has a temperature controlled medication necessity, portable heaters for winter, and then portable power supplies for home medical equipment that help in case of power outages. So those are the 5 devices. The next slide, we'll go through who actually can receive these. And while this is specific to climate, it also, again, is this framework for housing and nutrition, which will be later. So this is really allowing us to test our systems, test our contracting, really understand how we'll start to think about these different groups. You have to be an OHP member, current OHP member, and then also be in one of these, what we call transition groups or eligible groups. These are the populations we focused on in the waiver, wanting to really focus on stabilizing people who are going through either a system transition, so crossing systems, or someone who is crossing age categories that maybe brings in different types of providers. So this is our list here. And so someone who is getting these climate devices have to be an OHP member and be in one of these groups. So for example, recently released from incarceration, transitioning from Medicaid only to dual status, individuals who are at risk of becoming homeless, or a young adult with special healthcare needs. That's actually in 2025. So those are our transition groups. And then the next slide, that's on the left-hand side in purple. And then there's also a clinical need as well. So that's probably not too much of a surprise, but just being released from incarceration, you don't automatically get an air conditioner, but if you have a clinical need for an air conditioner, that this will support that work, then you would qualify for an air conditioner, for example. Really wanting to be thoughtful about the need for that individual to be having a health benefit from these devices, because again, we're tying these back to health related social needs. So I'm certainly, after a year of working on this, much more familiar with this, but I recognize that this can come across as complex. So if there are any questions, please feel free to ask. We are, when we think about this work overall, you consider that for climate devices, these are very specific devices. And so when we get to housing and nutrition, it really gets big. It gets much more vague. There's a lot of considerations. And so this is, again, a really good test for our system to get used to these framework, get used to these eligibility groups. And then we'll start to have to apply them to thinking about how that might be different for someone who may have a housing need. And what is that housing need? What is that nutritional need? For how long? All of those kind of more nuanced components of services. So next slide, just in case anyone who is listening is also really trying to understand this work for their own services, for their own patients, for example, the limitations on this is that we have to make sure that someone doesn't actually already have a device that meets their needs. We have been very aware of the additional requirements that come from giving devices. And so things like replacing filters is a necessity. So we did build that into the process. Device failure, there are warranties on the devices that we have identified as being eligible for purchase. And then utility costs. So we don't have utility costs purchased for HRSN. There are other ways that CCOs can pay for those for climate. Once and if someone becomes eligible for housing, housing can pick up utility costs. So this is kind of we have a little bit of a timeline between when climate goes live and then when utility costs may be picked up if that person is at risk of losing their housing in November. The next slide is just another reminder. So this is, I will acknowledge, we need to maybe consider thinking about how we've been naming and referring to these benefits. We have something that has historically been our flexible services in Oregon. Those are health related services, HRS. that CCOs use. Really important. They have been used for many years to be able to help patients get what they need that are maybe outside of typical medical benefits. And now we have this new layered on what CMS has asked us to call health-related social needs, HRSN benefit. And so there is a lot of there's a lot of words on this slide, but I think the point here is that there are other ways if someone doesn't qualify for our new benefit for CCOs to still be able to support climate related needs. So those are things that we're going to be tracking. We're going to be monitoring whether or not there are still requests for these types of devices outside of our waiver benefit. There's also a state program that is been reinvigorated this session, and some funding has gone into that to be able to support those individuals who are not going to qualify through this waiver benefit. So if we go to the next slide, here's our communications around this. There is a waiver webpage that we can put in here. We have a waiver newsletter that goes out bi-weekly. We have lots of people prepared in our agency in ODHS to be supporting through the call center. And then we have additional resources that are upcoming very shortly. So focusing on a web page, focusing on some FAQs as we roll this out. We've been working with providers and detailing a pretty amazing document we're calling there's a member journey and a provider journey, and they really are plain language, very clear, helps someone step by step understand how they would access the benefit or provide this benefit. And we've been working on finalizing those, getting them into multiple languages right now, and really happy with how those have turned out. Okay, and I think there's one more resource page there on the climate benefit. If people need those, I think the slides will be out as well. So any questions on climate before I move to our capacity building funds? Yes, please go ahead.
Thanks, Steph. I'm curious if you can talk about the really complex definition of determining clinical need.
Sure. So if you want to go back to slide 7. So one of the things that our federal partners, CMS, the Centers for Medicare and Medicaid Services, required is that we still needed to have a clinical need for HRSN services. A whole foundational part of what we were trying to do with this waiver was to not over medicalize it. We really wanted to be in a space where someone didn't have to come in with a diagnosis, because we knew that a diagnosis can be a restrictive, there's lots of reasons why someone might not have a diagnosis, whether it's access to care or access to trusted care or access to care in their language. And so we didn't want to limit it with a diagnosis, but there was a requirement from CMS to have a clinical component. And so there's been a lot of back and forth on this. This is part of what got approved in our protocol. And I don't think we have the slide here on the full list of clinical benefits. We do not, but I'm happy to share that. The clinical need broadly for this work is meant to be flexible enough for a provider to be able to identify the need. So broadly, a behavioral health need, broadly, a chronic ongoing physical health need. In some cases, pregnancy may qualify. In some cases, it can be age-based, that we just know that after a certain age, your risks go up. Any type of respiratory concern that would be worsened by heat. So there is a specific list. There are specific ICD-10 codes related to them, but it is meant to not be diagnosis specific.
Thank you, Steph. Go ahead,
Yeah.
Bill.
Hi, thanks, Steph, and apologize if you had addressed this question earlier, but I see that one of the eligibility groups is those transitioning from Medicaid only to dual coverage. What about people who are currently dual coverage? Again, I apologize if you already addressed this earlier, but it seems to me there's you mentioned just talking in response to Brenda's question that people over a certain age may be in a risk group, and seems to me the dual eligibles would even those who have been dual eligibles for a number of years might fall in that category. Could you just address that need for older people who might be clinically vulnerable but wouldn't fall in this transitioning category?
Great question. I will actually have to go back and look at the age, like how recently that transition has to occur. I can't remember if it's 1 year or 3 years. It is intended to be supporting the transition specifically. So part of what you'll see here is that in all of these cases, it's about like being able to access new providers, changing who your providers might be, opening up access to new benefits. I think what you're talking about is a need in our system. I'm not sure that that would necessarily be captured in just that alone. But then there are other ways in which there are transition categories. So these are like giant Venn diagrams. So someone who is dually eligible, who has been for a long time, but is at risk of becoming houseless, would then qualify. So they're not exclusive, and there are lots of other ways in which someone may qualify. But that's a good question. I will look at that specifically, unless someone is on who would know that, who wants to speak to it, and get back to you on that.
Trilby, go ahead.
Thanks. And Steph, I'm not that person who knows more about the specific length of the transition, so let me say that up front. But I did want to just take it up one level, Bill, and remind folks that this is such a new path that Oregon has blazed, right? And CMS looked at, are we willing to broaden the services that Medicaid covers in this really innovative way? And I think they felt like it was okay for them to take that step, because what Oregon had said is, we're concerned about people during these transitions in their lives that increase the risk to their health. So they really wanted to keep it narrow to transitions. So that's really the theme of how the approval was received in the first place, and to what Oregon proposed that made it possible to really step out into this new area of Medicaid services. So that, unfortunately, in that we'd love to do this for more folks, that does kind of govern the whole framework. So just wanted to put that out there as a reminder.
Yeah, no, I understand. And I think OHA and CMS should be applauded for this, for taking this step forward. I will note that on looking at slide 6, not all of those are transitional categories. That's like people who are young adults, with special health care needs, or individuals who are homeless. So it seems to me a category of people who are dual eligibles and meet the clinical needs as well, might be a needy group as well. I understand also that CMS may have tried to limit this in some ways, but if you could just provide a little more information on that, and for future consideration, seems to me, it just occurred to me as an area of need that wasn't addressed here. I'm sure there are others as well. I just wanted to raise this one. Thank you.
Absolutely.
Thank you, Bill. Tony.
Yeah, thank you very much, Steph, for the presentation. Really exciting work. And although it's not as far as I wanted it to go, and I think we had to pull back, this is really remarkable and a step. With that being said, I was just curious, in thinking of next steps to kind of get to those next levels where I think ideally we would like to expand this further. I was just curious the capacity for study and research to look about this intervention in our state, to say that, is there value? Is this creating change in outcomes? And do you think that we have a means by which we can do that?
Yeah. So part of what is required from CMS is a third-party independent evaluation. It's always a little bit delayed because they have to get data in that is, accurate and robust enough. But this is our largest evaluation of any of our waivers to date in terms of funding to support that, which is really exciting. There's currently work being done. The contracted evaluation design group is CORE from Providence. That's the Center for Outcomes Research and Education. They're currently developing the evaluation. If this is something of interest to the board, we would be happy to have you all weigh in on what that evaluation is and what they're looking at specifically in terms of outcomes. We also have some national interests. So there are some independent groups that are interested in evaluating our waiver. There have been lots of, we've been very fortunate as Trilby called us the trailblazer, which I'll appreciate and own, that's something that our state has done. Our 0 to 6 continuous eligibility, for example, has been the model for CMS. So there are 6 or 7 states who are following us, and they've asked those states to use our special terms and conditions as the template. So there is a lot of national work being done to kind of understand what this looks like in many states as well. But there are other ways for us to look at this. There's a lot of ongoing management. We were just having a conversation about, in 3 months, how are we going to know what impact this is having in terms of climate? And we don't want to wait for data necessarily. So we've been talking about how can we send out surveys to CCOs, see how many devices have been requested, have there been denials? What are those denials for? What is this looking like? To what we talked about earlier, are we still getting requests through HRS, through these other mechanisms as well? Or has everything really shifted? So we are trying to figure out some interim ways before the actual evaluations come out for us to internally know what's going on too.
Could I ask a follow-up on that, just with regards to HRS? It sounds like there was no change in funding for those programs with CCOs. It's really just delegated to individual CCOs to feel where they have that funding. Is that true?
So HRS has always been a flexible service that CCOs can use at their discretion for individual members. It's been really successful in some areas. I think other areas maybe have, focused in on specific topic areas, for example, so it's not quite as broad, and it does range. Part of what the reason we wanted to do this waiver was to create some equity in those HRS services and say this is a benefit across the state. Everyone who would be eligible is eligible equally. So we're really building off the knowledge and the success that HRS has created, especially in the pockets where it's been really successful, to create this benefit. And I think it'll be really interesting to see how HRS shifts or changes, because they will still have that flexibility, but it won't be for the benefit. So not to get too far into the weeds, but HRS is only available for services that are not covered benefits. So once something becomes a covered benefit, then it can be used for HRS. And so we will no longer see these climate devices for eligible members through HRS. I don't know if that was more confusing or not.
Ooh, that it does kind of worry me a bit. I don't want to belabor that. I think I needed more homework on that, and it maybe brings up the topic of this is something for us to take a little greater look at, because if we're implementing this policy in HRSN, does that have consequences for CCOs to distribute these devices? This is a more limited group that we see in front of us. For a lot of my patients, this isn't necessarily going to be for field workers that really are benefiting from air purification that I may have gotten them for HRS, right? Or air conditioners when we have our heat waves. And so I would be really interested in that question is, does this policy change have a consequence or a trade-off? Are you saying that? Are you saying that it has potential?
So that won't affect those individuals. If they're not eligible through HRSN, then HRS is an option. It's that we're kind of splitting it. And so that's where I think we're going to start to see how many people are we capturing effectively through HRSN? How many people still need these devices who aren't in these covered populations? So maybe the dually eligible that have been dually eligible for a long time, who still need these devices, but may not be in a transition group. And so what I will say is that it is clear that eligibility and all of the nuance here is challenging to make really clear. And so those are some things that we're working on. We just talked about, you know, how we can create better flow charts, make some really clear understanding of who is eligible where. The goal here is to broaden the number of people who would be eligible, not to reduce it.
Wonderful work. Thank you.
Yeah.
Thank you, Steph. I think next up is Melina.
Yeah, thank you for your work. I am curious about the member and provider journey you mentioned, and just what that looks like, what the timeline looks like, who initiates this benefit. If you could explain a little bit more on that.
For the member journey you're talking about? Yeah.
Yeah, so for the member journey or provider journey, you know, is this benefit initiated by the member saying, hey, I need an air conditioner? Or is this initiated by the provider saying, you have this condition, you need an air conditioner?
Mm-hmm.
And then how long is that timeline to actually get the air conditioner?
Mm-hmm. These are great questions. So it can be either. We do have a self-referral option. We also have a provider option, and it doesn't have to be a healthcare provider. It can be one of our service providers in the community who's going to be one of these HRSN service providers. So it could be the county, it could be a community-based organization, it could be local DHS office. There's lots of ways in which someone could be connected, and there is a form that will go to the CCO that will say, there is a need from this member. We think that they would be eligible. The member could fill it out themselves and send it in. And then the CCO will do some validation, if that's possible, to be able to say, oh yeah, they were seen at some point for a lung condition, or you know, we've seen this in the past. There is right now, I want to get back to you with the specific dates. I believe I actually don't want to say. My thinking is it is 14 days, but I want to confirm that before saying that. We are, you know, some of the conversations we've had is that may be our upper limit, but that we hope that this is going to be happening faster. Some of it may also be restricted by the actual device availability, which is one of the things that we've been monitoring and tracking, is just trying to understand, you know, if you're ordering from Amazon and they're out, what are our options? If you're ordering from Home Depot and they're out of the air conditioners, what happens? So kind of supply chain concerns as well, that could interrupt this. So there are ideally lots of options of what can be purchased, but those are things that our teams are monitoring, and kind of per usual with a demonstration project, we are learning as we go, because there really isn't, we don't really know what some of these concerns will be. So we're kind of always ready to go, ready to monitor and adjust, but certainly we'll have hiccups as we go.
Thank you, Steph. Kirsten.
Yeah.
Thanks. This is very exciting, Steph and team behind this. I had two clarifying questions and one question. So on all of these devices, most of them are very in need of an outlet. And so I wanted to clarify, like, that I heard you say that utility costs could be paid for through HRS funds. And that there's the intention to kind of package the climate device benefit with housing support services as well.
Could be. So this is all, so that's all both true and not the set in stone pathway, I guess.
Yeah.
So right now, climate device is launching. There is no utilities that were in our STCs packaged with climate. but we recognize that this is a gap. So when we do get to launching housing in November, there is a utility option that goes along with being at risk of losing housing. And so for an individual who qualifies for a device and is at risk of losing housing, we can be packaging the utilities with that. Utilities also have an upper limit of 6 months of coverage. So there are limits in all of these cases. What we really hope to see is that we are, to the degree possible, which we know is more work, but really thinking about this from an individual need and saying, here are all the things that someone may be eligible for. And maybe it comes through HRS, maybe it comes through county programs for utilities, federal support, and really saying, what are the options? How do we want to stagger this? Which ones should be used in what order? Those are all things we're trying to build some technical assistance on at the state level as well. You know, nutrition programs, there are really a large number of nutrition programs. They all have different eligibility. They all have different, you know, upper limits on the amount of time and what they can cover. And so how do we make this something that's accessible for an individual, that a navigator can help them access in the right order? Those are kind of all what we're trying to build towards. So for someone who is at risk of homelessness and would qualify for housing and has this climate device, they would likely get utilities packaged with that.
Great. Okay. And then my last question, in part because these are transitional times, as you called it, seems like it could be a difficult time to lug around an AC if you're transitioning to a different place, because you might not have a car, but you can't get another AC unit for quite a while because you've received that benefit. Anyway, to that extent, in the look back, in the assessment that this third party is doing, is part of that identifying barriers that prevented this from being successful versus like, because I could see this being like, that didn't work. It's not because it didn't work because the person didn't need the AC. It's because there was this other barrier to actually like making use of that benefit. Is that part of the assessment?
That's a great question. We're still building the HRSN evaluation design and what the questions are that will be asked. So I will look and see where and whether or not we're kind of looking at that. I don't know if it's an opportunity cost or, you know, how you want to describe that, but we can certainly flag that. I don't know if any of our evaluation folks are on now, but it may also be of interest to all of you to do an educational webinar on the evaluation and talk through kind of what is being considered and understand if you have specific questions as well. We'd be happy to put that together for you all.
Thank you, Steph. Great idea. I think what we're going to bump today's time and offer another 8 minutes for this topic. I apologize for running over, but I also know, Steph, that you prepared Community Capacity Building Fund slides for us to review. So let's go ahead and move to those now, and then we'll circle back with any last minute questions. Aim to take a break at 10:30.
Okay, great. Thank you for that flexibility. Appreciate that. So our community capacity building funds, these are, if you go to the next slide, these are really exciting for us as a state. It is an authorization from the federal government to spend up to $119 million on basically getting our systems ready, our providers ready to provide these benefits. So this is not paying for the services themselves. This is not paying for the devices. This is about getting us ready as a state, getting funds out there to really be able to add to the work, add to the capacity, add to the ability of these organizations to provide these services. The funds are flowing through the CCOs. This was an intentional decision to really support the relationship building and the network building at the regional and local level. As a state, we have really been pushing to make this as easy as possible for the requesting of funds. And so CCOs are using a standardized application, standardized budget request template. So regardless of, you know, whether or not there's overlap in CCO regions or whether or not, you know, they're applying to also be part of the in different ways. It's all going to look the same. The state can help with that to make sure that there's some support. And there will be community-based organizations and others that I've mentioned that will be able to apply for and then use those funds. Next slide is the actual eligible groups for these capacity building funds. So any of these types of organizations who will be providing climate services, housing services of any kind that are included in the waiver. So these are tenancy supports or housing navigation, rent, all of that, nutrition supports, and then outreach and engagement. So maybe we have specific organizations that work with specific populations, and they're going to support outreach to make sure that members are knowledgeable and about their eligibility, or that they can help support, that they're a trusted member in the community. There are also these outreach and engagement benefits that someone could apply for to support. If you go to the next slide, these are the 4 allowable uses of the funds. So an organization will apply, and in the application, they need to designate why and how they'll be using funds in these 4 categories. So we have technology. So these are billing systems, software that they may need. It may be, computers or laptops or systems like that, existing tech systems, integrated billing, screening service that they need, like a tablet to be able to go out and do screening. Development of business or operational practices. So this can be like development of business practices around billing, data sharing, program evaluation. How are they doing some of that? The 3rd category is in workforce development. So perhaps they will need support in recruiting, maybe some financial money for staff that will be supporting the services, necessary certifications, trainings, things like that. Those are all part of workforce development. And then the last one is around outreach, education, and convening. So maybe it is around pulling people together, supporting an actual in-person convening event for training that the organizations may need to do. They may be planning or facilitating some community-based outreach that would be really helpful in getting them ready to serve the community, supporting awareness of the benefit. All of that is, again, these kind of one-time funds to get us ready to get those funds out the door. The next slide goes through our timeline. And we're actually now into March. So the applications opened on Friday as well. That was a big day for our community capacity building funds. So CCOs have already signed our agreements with OHA to administer the funds. They are doing outreach now. That outreach should be ongoing. And then the applications are open for March, April, and all of May. Really wanting to give organizations time to be able to fill this out, time to understand what the CCO is looking for. We want to see conversations between these organizations and the CCO to say, hey, I think I'm going to need software systems. And maybe the CCO is like, oh, well, we were already going to purchase that, or we were going to do this. So really trying to understand and make sure that those dollars are used in a really effective manner to build towards these services. CCOs will be reviewing applications starting in May. It's going to be a rolling process, May, June, and July. They're going to be submitting to OHA. We are doing that intentionally, so the dollars go out after we've seen the applications. What we really are checking for at the state level is that we're seeing a broad number of applications. Ideally, we are seeing community-specific, population-specific organizations that are working with our historically underserved populations. We want to see that it's not just, business as usual. The same groups are getting funding that have always gotten funding. So those are the types of things we're looking for, and then we can have conversations with CCOs about gaps, maybe more outreach needs to be done to get other organizations to have interest. And then the funding notifications will be going out again in this rolling process in August and September with funds dispersed. We have about 50 million in this first year. There will be another about 50 million next year. we recognize that there may be organizations who are like, we have a lot on our plate. We don't know what this benefit is. It's going to take us time. We want to see it roll out. They may be interested next year. We don't want to penalize them. So trying to build this out over the next 2 years as we disperse those funds. And that's our plan. And so the last slide here is just more specifics on our website. There are, we have the protocol for what this is. So in case organizations are like, I have no idea if I would provide these services, go check it out, see what the services are. There's also, for every CCO, we have a contact for them and a web page. This was a requirement of their agreements with OHA, their contracts. There's the template on our webpage, and then some resources, including a plain language summary, some flyers if CCOs or other organizations want to help advertise, and then FAQs for a variety of audiences in multiple languages. Any questions there?
Thank you, Steph. What an incredible body of work. My goodness. And I love the level of engagement of the kinds of questions our board members are asking. It's reminding me to have you back more often. So thank you very much for all you do to help take this complexity and attempt as much as humanly possible to simplify it. I know that that's a big challenge ahead, and I can imagine, you know, I also deeply appreciate the connection to the CCOs and their realities of what it may mean to administer this benefit, you know, with ease. And so thank you for all the hard work to trying to make that road possible.
Yeah, thank you for having me. And there's lots of people behind me. I will also just say that, and even Suzanne Cross, who works with the board, has been really supportive and helpful in the CCBF work. So she's another resource for questions there.
Wonderful. Thank you so much. We're now going to take a 10-minute break. Apologies to those individuals who have already signed up for public comment. So we'll meet you back at 10:40. Look forward to seeing you then. Thank you. Welcome back. See some familiar faces. Thank you so much for your participation and engagement today. It's really great. Next up on our agenda is our public comment, and I'll read some notes around that by way of introduction. So the Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most profound ways and powerful ways that we demonstrate our commitment to listening and learning. Deep listening means that we won't respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject or correct inaccurate comments that are shared as fact. We will, however, bring it into our full awareness, understand that it's an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that the time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not necessarily a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and in the event that that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a 2-minute timer for each commenter. We kindly ask that commenters include their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. I think first up for our public comment is Dr. John Santa. John, are you here?
I am.
It's good to see you. Welcome, or be with you. Welcome.
Thanks. Ready to go when you are.
All right, we're ready when you are, John. Go ahead.
My name is John Santa. I'm a retired physician and health administrator. I am opposed to the Optum acquisition of the Corvallis Clinic and concerned about the HCMO process currently underway. A decision on the preliminary review has been delayed until March 8th. A reason for the delay has not been provided to the public. Despite 300 plus comments and 600 signatures in a petition opposing the transaction from Corvallis and Mid-Valley residents, including Corvallis Clinic patients, there's been no attempt by HCMO to meet with the public and acknowledge and respond to their extraordinary concerns. There's been no public statement from the Corvallis Clinic. I was surprised yesterday in response to a public records request to see that HCMO is sharing documents with Optum and meeting with Optum and the Corvallis Clinic. Indeed, one email suggests that Optum has already received a document describing conditions of the approval. And in response, Optum requests to see a draft of the approval package. They note this request is consistent with past OHA practice. Where are patients and the public? But there's a second reason to be concerned. Last week, Change Health, a health data clearinghouse owned by Optum United Health, acknowledged a ransomware attack by Black Cat. United has informed the SEC and posted content about the attack on its web pages. Change Health and United Health acknowledge that key processes are effective. Organizations are being disconnected from Change Health. A significant impact continues, including manual approaches. Change Health has not set a date when connections can be restored. I guarantee you that every chief information officer who works for an organization with connections to Change Health or United is scrambling. Significant harm to the Corvallis community in Oregon could occur if these problems are not disclosed and completely resolved before any decision is made. There is a better option that resolves these issues. Move to a comprehensive review and organize a community review board to hear the whole community regarding this transaction.
Thank you, John. Thank you very much. Next up, we have Bruce Thompson. Bruce, are you here?
I am. Can you hear me?
I can. Thank you very much. When you're ready, we'll start your 2-minute clock.
Thank you for this opportunity. I am Bruce Thompson with 25 years of service as a family physician and as Benton County Health Officer. Since retirement from private practice 10 years ago, I have been an advocate for affordable, equitable health care for all people in Oregon. Today, I am presenting my understanding of the negative impact of massive corporations' business models on the health of medical providers as well as patients in Oregon. In the past 18 months of healthcare market oversight HCMO program becoming operational, the agency has seen an increasing number of out-of-state for-profit organizations bringing a Wall Street management model to Oregon healthcare. These corporations overwhelm the many efforts by state government, legislators, agencies such as OHA, as well as volunteers and advocates of healthcare reform in Oregon. Large corporations are unfamiliar with the amendment to the Oregon Constitution, which addresses affordability in healthcare, nor are they familiar with the efforts of the OHA Committee on Containment of Healthcare Cost Growth. In short, they are unfamiliar with the organic social culture of how Oregon has incrementally improved healthcare for a large portion of Oregonians. Large corporations' primary purpose is to maximize earnings for their shareholders. Over the past 2 to 3 years, there have been numerous articles and editorials in medical journals that document how this business management model of healthcare can compromise patient safety and negatively impact patient outcomes. David Batten, in his testimony to the Oregon Senate Healthcare Committee on November 6, 2023, has echoed these significant findings. Concurrently, in the past 3 to 4 years, recognition of moral injury to healthcare workers has been defined and discussed in medical journals and news media. Moral injury results from being confined by a business management model that conflicts with a medical professional's training. In the pursuit of maximizing earnings, business models of management create obstacles and protocols that impact a medical provider's ability to provide timely patient care. These business models also create earnings by minimizing medical staffing. Moral injury contributes to healthcare workers' shortages of physicians, nurses, and other trained medical providers. I offer a short personal story to illustrate moral injury.
Dr. Thompson, thank you so much for your testimony. I wonder if you could submit that personal story in written format. I know our time is up.
Yes, I will submit it. Thank you for this opportunity to express my significant concerns for these consolidations, one of which is occurring in our community.
Yes, thank you so very much. Thank you. All right, next we have Michael Huntington to share public testimony. Thank you. Michael, are you here? I'm not hearing so. Tara, have you checked to see if Michael's available?
Yeah, he confirmed over email, and I see that he's on right now, and I've asked him to unmute. He may just have stepped away or be having an IT issue.
Okay, thank you. Well, we may be able to welcome him back in the time we have today for this agenda topic if he does arrive. Give him one more minute. Okay.
Brenda, can you tell me who I should send this story to?
Yes, absolutely. Thank you, Dr. Thompson. Tara Chetak can support you. She'll send you a note in the chat itself.
Okay, very good. Thank you.
Fantastic. Great question.
Yeah. And Brenda, we can call for Mike Huntington at the end of the meeting since he can't hear us right now.
Okay. Thank you so much. Thank you, everyone. Okay, next up for our agenda, we have a an update from our Cost Growth Target Advisory Committee, and a proposed membership slate change. Bill, as our liaison to that committee, did you want to say a few words to introduce the topic?
Thanks, Brenda. Yes, just briefly that we have a vacancy on the Coast Growth Target Advisory Committee. And Sarah Bartleman, I think, will be presenting that. As you all know, this is a very important committee since the Cost Growth Target program is one of the key tools we have to ensure affordability going forward for organ consumers, patients, and purchasers. Also, I'll mention that the Cost Growth Target Program's Rules Advisory Committee is active right now, and there's opportunity to provide input on those rules to formalize some of the key elements of the Cost Growth Target Program. I'll turn it over to Sarah.
Thanks, Bill. I think we are here today for a request for the policy board to appoint a new member to fill a vacancy for the Cost Growth Target Advisory Committee. So I'm going to go really quickly through some of the background and present the new member. And I guess for the record, hi everyone, I'm Sarah Bartleman. I use she, her pronouns, and I manage the Cost Growth Target Program at the Oregon Health Authority. Next slide, please. I just want to remind the board that the process that we use for the Cost Growth Target Advisory Committee is a little different than some of the other committees because this committee is not in statute and we don't have defined membership seats that were legislatively given to us. And so in 2022, we had a long discussion with the board about what the ideal composition for this committee would be. And we looked at aligning across 3 different domains. So sector, demographics, and expertise. We agreed on a 20-member committee with some ideal thresholds that if we met these certain parameters, that would be the ideal committee, and that's how we would do seats for this group. So I have linked to the ideal committee composition if any of the newer members want to look back at that, but that is our guiding process for this committee's appointments. Next. Just to break that down by sector, the committee is balanced 50-50 between healthcare industry, payers and providers that are subject to the Cost Growth Target Program, and then non-industry, so including consumer advocates, consumer representatives, employers and purchasers, and research perspectives. Next. We were recently asking you to appoint members back in October. You filled 2 vacancies and unfortunately 3 vacancies. Unfortunately, one of our newest members has had a change in career and had to step down. So Kate Dennison with the Oregon AG's office was appointed as a consumer advocate to a consumer advocate seat on the committee and has had to step down, unfortunately. So she was with us for 1 meeting and before she had to leave, and now we have a vacancy that we were looking to fill. Next slide. We opened a call for this vacancy for a new committee member between mid-January and mid-February, so it was open for about a month. We reached out in all of our standard ways, so communicating with our committee, with our technical advisory group, with our distribution list that has over 5,000 subscribers that are interested in this work. And then staff did a lot of targeted recruitment to various advocacy groups and organizations across the state to see if there were other folks who might be interested or might be a good fit. Next. We received 2 applications for this vacancy and considered them against our criteria. So looking at applicant professional and lived experience, the existing representation on the committee relative to that ideal composition, and the impact that either of the applicants would have on the representation across our 3 different domains. Next. We are recommending for your appointment, appointing Eli Rushbanks, who's the General Counsel and Policy Director at $4, which is an Oregon and Washington nonprofit that works with patients on financial assistance, medical debt, particularly focused on hospitals. They have a national presence, but are located in the Pacific Northwest. And Eli brings expertise in patient experience around medical debt, deep familiarity with Oregon's hospital community benefit program, hospital finances, and healthcare reform. I'm happy to share more about his background, but he is passionate about this. Some of you might remember, I think we shared it with the policy board. $4 they've put out some really great reports on hospital financial assistance and impact on consumers and affordability over the last couple of years. Next slide. So this would be our revised slate. You can see the current members and proposed new member, Eli. Next. And I'm just going to run really quickly through what the proposed slate, including Eli, would do to our committee composition across the domains relative to the ideal composition. So these bars, let me just orient you to this graph. So the blue bars are the proposed slate. So the percent of committee members in the proposed slate that meet one of these demographic categories. And then the lighter gray bars that they're superimposed on would be the ideal committee composition that the board previously agreed on. So you can see the current proposed slate cumulatively would be a little bit below ideal in terms of gender representation, meeting ideal composition for people of color. We continue to not have disability representation. This has been a problem since our initial appointment of this committee. We've really been underrepresented here, despite efforts to change that. And again, reflecting that this is self-reported disability, and so we may have applicants who identify as a person with disability and have not disclosed that as part of the application or as part of their committee materials. And we do exceed the ideal slate for LGBTQ representation. Next. Geographic representation. We are looking to ensure that a portion of the committee is outside of the Portland metro area, and we continue to meet that with the proposed slate. You can see the distribution across the state here, noting that this committee primarily meets virtually, and we do not require that committee members live in Oregon as long as they are working and representing members in Oregon. Next. And then finally on expertise. So this graph is a little bit different in that these aren't going to sum to 100%. Just want to note that because we recognize that our committee members bring lots of different expertise across their careers and their professional and personal experience. And so this is a sort of check all expertise that applies. And so it's not one member with economics experience. It's of any of our committee members, 10% or 2 of them have health economics expertise. So you can see that we exceed all of our ideal composition for different kinds of expertise that committee members would represent. Okay, and I think next slide is just to ask you if you approve and any questions or discussion about appointing Eli to the committee.
There are other questions for Sarah, either about the process or about the appointment itself? Not seeing any raised hands. Bill, did you want to take action or propose action?
Yes, I would like to propose move that the board approve the appointment of Eli Rushbanks as a member of the Cost Growth Target Advisory Committee.
Thank you, Bill. Is there a second?
Happy to second. Oh, sorry.
We'll take Carly. Thank you for your second, Carly. Any other discussion? All those in favor signify by saying aye.
Aye.
Aye. Aye.
Any opposed? Any abstentions? Great. Welcome, Eli. Thank you, Sarah, for your hard work and the recruitment. And on behalf of the board, you know, it's always exciting to see such strong participation in our committee. So thank you very much for that. Great.
Thank you. Can I make a quick plug? I just want to let the board know that we will be coming back to you in May with a more broad slate for approval. So our initial committee was appointed for 2-year terms, and those 2-year terms will be up. And so we are in the process of checking in with all the committee members about interest in extending and continuing with the committee. But we do plan to come back to you with an updated, broader set of members later this spring. So thank you in advance for that.
Thank you, Sarah. And we're also looking forward to seeing you again in June, you know, as a big feature of our meeting that month. So again, for your hard work, we appreciate what you do. All right. Thank you. Now, next up, Kirsten will be, as our liaison, provide the introduction to our quality incentive metric presentation for today. So Kirsten, I'll just turn to you and let you take it from here.
Good thing. Thank you. Yeah, as the liaison to metrics and scoring committee, it's my pleasure to welcome Stacy and Derek to present to us today regarding CCOs and the metric incentive program. This is one of the board's priority work areas, and the incentive metrics program has grown to be quite large, as has our Medicaid program generally, but it impacts, in theory, all of our OHP members. And I think importantly for today, like this program is being evaluated and changes potentially in the future. So I'm very anxious about the metrics program becoming a powerful tool that can be put towards our health equity goal, aligning, I've talked about in the past about like aligning our tool belts and our tools with our goals. So how are we using this to incentivize and reward those who are notably taking action to reduce health inequities? And I think that if we agree, we as a board should, but I would recommend that we take action to kind of cement that intention in place. But with that in mind and with open minds, let's hear first from our presenters and then the discussion.
Good morning. Thank you so much, Kirsten. My name is Stacy Schubert, and I use she, her pronouns. I'm the Director of Health Analytics in the Health Policy and Analytics Division. So in addition to the quality incentive metrics that we're going to discuss today, I do want to mention there are a few other things that Health Analytics covers. Some of them you've probably heard of, including hospital and claims data collection and analytics, the 1115 Medicaid waiver evaluation, and behavioral health analytics. Next, I'll turn it over to Derek to introduce himself, and then I'll get started on the presentation proper.
Hi, good morning, board. Derek Franke, he, him pronouns, manager in health analytics with the Quality Incentive Program.
Thank you, Derek. So next slide, please. So before I get into the bulk of the presentation, I do want to say that you're going to be spending a bit of quality time with Derek and me this year. Today, we're talking specifically about the history of the metrics program. And then next month, we'll return for part 2, which we will foreshadow the contents of a little bit later on in this presentation. And I do want to apologize to board members who have been with the board for a while. You've already heard about some of this, so perhaps you can multitask, or perhaps you'll learn something new. I mean, there are good options. So let's move to the next slide. So as Kirsten mentioned, Oregon's incentive program has existed for quite a while, since 2013 was actually when it was stood up. It was approved starting in the 2012 1115 OHP demonstration waiver. And in this quality incentive program, coordinated care organizations can earn bonus funds based on how well they perform on a set of measures of healthcare access and quality. In 2016, the Center for Medicare and Medicaid Services codified rules that incentive and withhold programs are permitted under certain specified conditions. And that just means that we no longer need waiver authority to have our program. So the conditions that allow us to implement these programs is that first, the program must meet specific financial conditions. And then the second is that the program must be in any state's quality strategy. And that quality strategy is the roadmap for states and contracted health plans to assess quality of care that beneficiaries receive. So for most of Oregon's programs, the program history in Oregon, we have operated what is identified under the last bullet, an incentive arrangement. So these arrangements are when a percentage over and above capitation rates can be earned based on performance. And in incentive programs under this rule, the maximum percentage that's allowed is 5%. So next slide, please. The Quality Incentive Program was originally designed primarily to reward CCOs for providing exceptional care and continually improving quality. This slide shows a selection of metrics that have been incentivized, and at a macro level, this program has delivered results. But, and we're going to talk about this more at our next OHPB meeting, this program was not designed to advance health equity. Over the past 10 years, the secular landscape that we're operating in, as well as OHA's priorities and OHPB priorities, have really changed quite a bit. So while we've added more upstream metrics, including the social determinants of health screening and referral metric, and the meaningful access to healthcare services for persons with limited English proficiency metric, in many ways, the program really has not kept pace with the most recent waiver and the priorities of this board and the priorities of OHA. Next slide, please. This slide shows the percentages and amounts of the bonus payments over time. And you may hear me use the term quality pool. That's a term that we also use, and that represents just basically the big pool of bonuses available to CCOs. So as you can see, the program started in early years with relatively small percentages, the 2% in 2013, and then it got up to 4.25% for the first time in 2016. It went down for a little while in 2019, and I believe that was due to budget considerations. And then it has gone back up to 4.25% in most recent years. And again, that is 4.25%, or any of these percentages represent a percentage above and beyond the capitation rates that CCOs receive. So that is the per member per month amount of money that a CCO receives for coordinating and delivering the care, healthcare to beneficiaries. So what you'll see in particular over the last several years is that those dollar amounts have gone up pretty substantially. And that's in large part due to the fact that during the pandemic, most people on Medicaid stayed on Medicaid during the public health emergency. And so Medicaid rolls we had a lot more members, for instance, in 2022 than we had, let's say, in 2019. Next slide, please. So there are several important things that I'd like to make sure you understand about incentive program payments. And these are aspects of the program that seem to be really commonly misunderstood. And I think that's because they're pretty far under the hood of this big machine that we've built. The first is that all incentive program funds are paid out entirely each year. So that means no money is ever left on the table. While certain CCOs may earn less, that only means that other CCOs earn more. And I'll show you an example of that in the next slide. The second is that CCOs don't need to meet all metrics to earn 100% of their incentive pool payments. Currently, the program is designed so that a CCO only needs to meet 75% of their metrics to receive 100% of their payments. Let's move on to the next slide, please. So this is just an example. You can read quite a bit more about this in one of the linked documents to today's materials, which is the CCO Metrics 2022 final report. So for example, in 2022, so that's performance year 2022, there were 14 metrics that were incentivized. And in that year, any CCO that achieved 11 or more metrics earned at least 100% of their quality incentive bonus funds. So as you can see here, All Care, Health Share, and Umpqua Health Alliance all received 100% or more. I'll get to the or more in a moment. And that's because they all had at least 11, they met at least 11 of the metrics. So you may be wondering, why are some of the CCOs showing as earning more than 100%? Well, remember how I said that all funds are paid out every year? When other CCOs, and in this particular example, although these aren't, I'm not picking on anybody, other CCOs also earned less. But in this example, Intercommunity Health Network and Pacific Source Marion Polk earn less than their full incentive. And so when that happens, the unearned money is entered into what we call the challenge pool. And these are designated metrics, and Derek will talk a little bit more about this committee, but the Metrics and Scoring Committee picks designated metrics from among all the metrics incentivized for a particular year. And if the CCO achieves those metrics, these special designated metrics, which in this year I'm showing you, there were 4 metrics in the challenge pool. So if a CCO achieves those particular metrics, they're eligible to earn additional money. And so that's how we get to above 100% for these particular CCOs. Next slide. So now I'm going to turn the rest of the presentation over to Derek. Thank you.
Derek, it looks like you're still muted.
Thank you. Can you hear me now?
Yes, thank you.
Okay, thanks. Yeah, thank you, Stacy. And I'm first going to kind of dive us a little bit more under the hood, I suppose, in terms of how measures and benchmarks are selected. So next slide, please. So first, for measure selection, for a number of years, there were really 2 committees that were involved in selecting measures for CCOs. The Health Plan Quality Metrics Committee, or HPQMC, maintained a list of nearly 60 measures. It's called the Aligned Measure Menu Set. And the idea there was really to bring in some standardization across CCOs, the Health Insurance Exchange, and also our PEB and OEB partners. So our benefit plans for educators and other public employees. And the idea there was if all these groups were interested in tracking, say, diabetes care or maintenance, that we would have a common metric to be able to do that. So they kind of set a common set of metrics that folks could choose from. Then the Metrics and Scoring Committee would select which of those measures to incentivize for CCOs for a given year. This board, the OHPB, had a role in that HPQMC was a committee of this board. And then you can see on the other side of this slide that my team also facilitates a CCO metrics tag group, a technical advisory group. That's a bit more of a forum just for metric implementation, specification changes, maybe sharing some workflows or best practices that are happening in clinics. So all these groups had some influence and were part of the overall kind of metrics landscape as we would talk through measures and develop things. There's a few reasons why this slide says historical though. So for the 2025 measurement year, metrics and scoring is really selecting directly from the CMS core set. So Stacy talked a little bit about the Senate Bill 966 changes, and that was one of the most direct changes there, that our downstream measures, our more clinical based measures, we're going to get our standardization by selecting from the CMS core set. And that was really one of the main functions of HPQMC, was to kind of set the menu. Further, HPQMC has been on hiatus for about 18 months now. Among your media materials, we included a memo that my colleague Phil Schmidt from Government Relations and I presented to the board in September, talking a little bit about the pause there. As I said, one of the primary functions of HPQMC was really to set that measure set, and the movement to the CMS core set has kind of taken a little bit of that one of the main roles there of that committee. So they're going to remain on hiatus for now while we still study some other changes that we might want to see within this program. Next slide, please. Now, once the measures have been chosen, metrics and scoring then also sets the benchmarks for that CCOs are aiming for a given year. So that given that these are bonus dollars, really we're aiming for a high level of performance. Historically, benchmarks have been chosen to be quite aspirational. Prior to the pandemic, they were typically in the top 10 to 25% of Medicaid plans nationally. So aiming for like 75th percentile among all Medicaid populations. Next slide. At the same time, there was a recognition that CCO all started from different with barriers and different other. So the committee did not want power that some CCOs might just throw up their hands and see something as unattainable. So the initial metrics and scoring committee decided to include improvement targets as another possible component of the program. That means that CCOs could meet a measure by meeting the benchmark or by making a significant step towards the target. And it might be enough to meet the measure that way. So I'll show you the math on the next slide. Next slide, please. So here's one more example with that improvement target concept. This one shows math on just a hypothetical scenario. Say we have a benchmark of 75%, and last year the CCO got 25%. So there's a 50 percentage point gap there. For the coming year, they would need to make up 5 percentage points or close 1/10 of that gap. That would be a significant enough improvement for them to be considered as meeting the measure. Next slide. So the result of this is that CCO performance can vary widely, even among those that are meeting the measure. So in this example, and this is not hypothetical, this is right from our metrics dashboard. You can see that the top performing CCO there, the light gray bars here are trend lines of individual CCOs. The top performing CCO there is at 79% and passing the measure pretty easily above the benchmark. But also some of the lower performing CCOs still also meet the measure. You can see the other red line pointing to a CCO who met the measure even at 43%, because that was a significant increase from the year before. So you can see that those, a few of the lower performing ones there were making a big jump up from 2021. Next slide. Let's talk, I'm going to zoom back out a little bit now and talk a little bit more about some kind of overall results and program impact. Next slide. So here's a few examples, and these are kind of purposely pre-pandemic. We've found that across all of our measures, we really did take a hit and it's been climbing back up. So just to set that aspect aside for a minute, here are a couple of examples that are really pre-pandemic. The percentage of children in foster care who received mental, physical, and dental health assessments continues to increase. CCO performance on this measure improved over 200% since it was first incentivized. So it was below 30% in 2014 and was 90% in 2018 and 2019. We also saw that cigarette smoking prevalence had declined from 29% down to 24%. So really some evidence that what we incentivize can make a difference and drive some change. Next slide, please. Now there was an independent evaluation that was part of the original Medicaid waiver in 2017. And it really identified the incentive program as one of OHA's strongest levers in terms of measuring performance and driving health outcomes. So when we had this evaluation done, we had some pretty aspirational benchmarks. It wasn't necessarily looking at health equity, but this was overall looking at the effects of the waiver and some of the results of incentivizing measures. As they found overall, what got incentivized improved, and there was a difference there in really driving home results. So there were some recommendations that came out of that in terms of things that we could continue to push with the program. They encourage us to continue increasing benchmarks, introducing new measures, and really driving innovation and raising our standards year after year. Next slide. Stacy mentioned a bit that some things have changed significantly since the beginning of the program. Certainly the amount of money has grown over the years. So we're now at over 300 million the last year and this year. At the same time, we're not implementing some of the recommendations of the evaluations. We have not necessarily introduced many new measures. In fact, we're right now holding CCOs to fewer measures than we did previously, incentivizing fewer. And actually, we've decreased the benchmarks for a number of measures. Over a third, the benchmarks decreased or stayed the same over the last few years. Next slide. And the other thing we've mentioned that's changed substantially at OHA, really within this board, within our society, is of the quality. What was the first waiver or the independent review of this program years ago? Metrics and scoring with our equity and inclusion division to do equity impact assessment of these work and really see what kind of on equity.
Derek, I don't know if you can hear me. We're getting some intermittent internet from your audio. I wonder, Stacy, if you could pick up this slide from here. That's a reasonable request. Derek, you're frozen, I think, on our screen. Yeah.
Yeah, I can absolutely pick it up. Derek's been having some internet trouble yesterday and today, so I actually anticipated this might happen. So I'll just start from the top on the slide, if that's okay. Another thing that's changed substantially at OHA, and then of course within this very board, which I've already talked about, and in our society at large in the last many years, certainly since the pandemic, is a focus on equity. And this really was not at all in mind when this program was first designed. And that's not to say anything bad about OHA or the work that we did. It was a phenomenal design when we first started, but we're in a very different place than we were 10 years ago when this program first started. So several years ago, OHA conducted what we call an equity impact assessment of the committee's work on selecting measures for the CCO Quality Incentive Program. And this assessment analyzed CCO incentive measures considering OHA's health equity definition and strategic goal to eliminate health inequities by 2030. And I do want to be very clear that this health equity assessment, or the equity impact assessment, was conducted both by Health Policy and Analytics and by the Equity and Inclusion Division. We worked very closely together on this. And the most important conclusion from that assessment is that the populations most affected by the measures should have a say in which measures are selected and how they're implemented. The assessment was a first step in our thinking through what changes could make a difference to this program, and thinking about what we can do to ensure that we're leveraging these dollars to drive towards our 2030 goal. And then next slide, please. I believe this is the last one. I'm circling back to a slide that I showed you early in the presentation to preview our connection with you next month. So today's presentation was the history of the program. We've done a little bit of foreshadowing about this next presentation, but we'll dive into that a lot more deeply at the next time we're here. We'll talk about some changes that came from Senate Bill 966 that passed in the 2023 session. Those changes are related to the actual structure of, not the structure, but the designation of types of metrics into upstream and downstream. And we'll also talk a bit about the CMS core measure set. We'll talk about centering equity, and then we'll also talk about a study that has been contracted that's required under Senate Bill 966. And we're hoping that the contractor who will be implementing that study will be joining us at that time. And then we will also talk with you about the 2025 legislative session and our hopes and dreams for that. So that's where I will leave it. And I think we have one more slide, which is just our usual slide. I love this slide because I always lose at Scrabble to my husband, and I would love to have some question mark Scrabble tiles. So I'll leave it there.
Thank you, Stacy. Thanks so much for that. And I really appreciate the preview of the topics that you'll bring forward for us next month. I think that really helps shape the question and answer period that we've scheduled for today's conversation. So I think just turning it to Kirsten first, if there's anything you want to emphasize based on what we heard. And then second, to turn to our board members and ask you to consider this question. If you were asking for additional information from Stacy and Derek and Kirsten at our April board meeting, what else would you like to know? So Kirsten, first to you.
Sure. Thank you, Brenda. Thank you, Stacy and Derek, and all the committee and all the staff people behind this work. I do want to flag for the board that SB 966 has a change in OHPB's role related to metrics as well, which is part of why we're doing this deep dive, because metrics will become more of a responsibility of this board than they have been in the past. And so let's listen and learn and go down this journey together. And then I did want to underscore that I am deeply supportive of this shift of this review, to take a look to say, how are we using this tool to help achieve our 2030 goal of eliminating health inequities? Because as you can see, it is a very powerful program, and at times has been incredibly effective in making change in what the quality of care delivered and where that focus has been. And so I would like to give a heads up that at the April meeting, I would like to propose that OHPB, that we as a board adopt a pretty simple high-level value statement about the future state of leading with equity in metrics work. And I think that just a few sentences of that North Star about OHP believing in the CCO incentive metrics program structured to align with the goal of eliminating health inequities. And to do that, it has to have community voice and voice by the people most impacted by it. And so it's something very simple like that, which happy to bat around with this crew, but I did want to give you a heads up that that's what I would love to see us do. And so as we're hearing that and thinking through these presentations, would love your feedback and thoughts on that statement, or on such a statement over the next month. And yeah, let's ask our questions and dig in.
What questions do you have for Stacy, Derek, or Kirsten as the liaison? Carly.
Yeah, thank you, Stacy and Derek. This background is super helpful, and I feel a lot more equipped to have a conversation knowing the context. I wonder if for April, I think, Brenda, to your question, if there's an opportunity to hear a little bit more about the metrics or the alternatives that have been on the table that maybe would align more closely with the 2030 goal. You mentioned the kind of social needs screening. I know there was an interpretive services metric, and just having some understanding of what's been put before the committees, what challenges with those metrics have existed. I know, health equity work doesn't always align super easily with kind of clear-cut quantitative data. And so I think it might be helpful for us to ground ourselves in what's happened in regards to this work up to now. And then any metrics you see other states using, or you know, I know national bodies sort of recommending that, again, come closer to the notion of health equity and eliminating inequities and disparities. I think that could be really helpful.
Thank you, Carly. Tony.
You know, I really appreciate that comment, Carly, and it got me thinking. I've really appreciated some of the prep and, you know, for us to learn outside of this forum in preparation for the meetings. You know, the cost growth target just did one on hospitals, and that was nice. I'm not entirely familiar with SB 966, and I'd love to see more information on that. Thinking of Kirsten, to your comments, really appreciate those. I sit in a federally qualified health center, and metrics is something we go around and around on population health. And these are carrots and sticks that have been used for over a decade. And I think we do need to reshape the way that we're thinking about health in the settings we're delivering them. And how we've practiced that as far as value-based care over the last 10, 15 years, is that moves in the direction to 2030 goals of equity. I think also the cautionary tale that we need to learn from over this last 10 years is the challenges that when we move these levers and these policy decisions at a state level, that they have downstream effects. And that has to do with the boots on the ground that have to pay attention to 150 different metrics in a 15-minute visit. I've been a primary care doctor for a while, and I've seen a lot of people coming out of my halls and are not able to meet the requirements. And so I think I really appreciate metrics and scoring and the insight in that. But I think we need to think about who is best to deliver health equity. And we have across this country, you know, MedPAC recently did a review with CMI and value-based care and the ACA evaluation studies, and they weren't as clear cut as the return on investment that we were hoping to see with them in that. And I really appreciate this forum and us thinking that if our goal is 2030 health equity, we need to think outside the box and think of different ways to do that. And just, you know, my concern is a health provider the person to bring us health equity in this? And I would argue it's not. We know that social determinants of health has to be a team-based care. I remember I was chair of evidence-based guidelines for Yakima Valley farmers for a while. And one thing we came up 10 years ago was implementing SBIRT and depression screening. That time, the review was that if you do not have behavioral health or the next entity which you can connect that person, then the question should be, should you be doing the intervention for the screening? And we know that is really helpful, but we also need to bolster and figure out how do we equip the health system with the team members they need? Because you asked them to do this in a 15-minute visit. Now they have a patient that's suicidal, but they have nowhere to go. And that's a challenge. And I think we need to be very thoughtful about when we're doing these metrics and scoring, what those other effects are and what are those other components. So, and too long-winded here, but metrics and scoring has been something I've been very interested for a while. So I appreciate us looking at this.
Thank you, Tony. Other feedback or questions? I wonder if we can bring back up slide 18. I've got a couple questions for you, Stacy, and to see if that's a way that we can kind of frame them a little bit. It's in the spirit of thinking about the equity impact assessment and the key findings that you've discovered already. So I think the spirit of my question is a bit toward it's a large question, what gets in the way of acting on our key findings, the things we already know about? And how many of them are structural decisions that you think this board can be influential in? So whether that's something you want to take on in April, if it's something you feel, compelled to speak to now, either one would be useful.
I think we're going to talk, as intended, the conversation in April is really to talk through what gets in the way and in which areas the board can be influential. So I think it would, particularly knowing that that's an area that you have a strong interest in, Brenda, we can use that to shape our presentation. The presentation obviously has not been developed just yet, but there are some structural elements to the way that the metrics and scoring committee is designed that create a barrier to engaging the folks who are most affected by this program. And then there are a number of programmatic design decisions that are not necessarily structural barriers, but they may have some stickiness because of the way the program has operated for such a long time. So that's at a very high level, that's my response, but we'll dive into that more deeply next month.
Thank you, Stacey. You know what, I think just to give voice to the comment that you made earlier that seemed to really connect or at least resonate with me, which was the original intention of the program and its founding principles and design were not intended to do what we're asking it to do now. And so over time, when I've seen this tension play itself out in, health outcome data that is best practice standards and as part of the CMS core set, as though it's in opposition to other more innovative Oregon-like ways of doing the work that we do, including the questions of how do we actually measure the impact of health equity. That tension, in and of itself, I think is a very healthy orientation. The question is how do we align those principles toward a larger vision? And I think that in part is the biggest challenge of the group, at least from my kind of outside observer witness perspective, and one who also helps lead an organization of community leaders and clinicians who are doing this work day in and day out. So I think a little bit about how if we transform the focus area of the committee's work itself, through these simple statements that Kirsten is inviting us to consider, what other tensions are we not paying attention to? If that makes sense. So where are those trade-offs? And not that it has to be an either or, but just to be really mindful of any bumps in the road we should be anticipating in advance of a future decision we might be making. Yeah. Other reactions to this topic, we have the luxury of time right now. So if there's anything else to support Stacey and Derek in preparation for next month, Kirsten, anything else that you'd like to make sure we cover today?
I do want to highlight something very useful that Tara put in the chat, which is a link to a presentation that Derek and I think Phil Schmidt was with you, did last fall that I think especially for those of us that like to hear something, marinate on it and do some pre-thinking and then come back, might be worth reviewing, which was a synopsis of this SB 966 bill. So it goes into, so some of it will be repeated next month, of course, but I think that can be helpful if people want to dive into that and do some pre-thinking. Other than that, I will just, I'll leave it at that. I really appreciate, sorry about the dog. I appreciate the staff and state of Oregon looking to continue wrestling with how to evolve and best serve, best provide care to a significant portion of our population. So I appreciate this work.
Thank you, Kirsten. I'll kind of bookend the topic before we do a couple other things right before we close. And I'm still re-inspired by our OHPB health equity definition. And I think this particular conversation really speaks to the comment of recognizing, reconciling, and rectifying historical and contemporary injustices through the distribution and redistribution of resource and power. And so when I think about like what is really being called of us as a board right now, and in support of alignment or realignment, this seems like a really beautiful opportunity to stake claim and really set direction for not only the program, but for the state in something that we claim to be really critically important to us as an organization. So thank you, Stacy and Derek, for your time today. It was a great presentation. And even though I've been on this board for a while, I found it to the refresher to be really useful. So appreciate all the layers of detail that come into this work. Okay. I've received a note from Tara that Mike Huntington has joined us now and is now ready for public comments. So we've got Mike, if you can come on camera, if that's possible for you. If not, we'll make way either way for 2 minutes of public comment. Are you here for us? Back with us? Looking around.
All right, Mike had just emailed me a couple minutes ago saying he was here and ready. So Mike, this is your time to shine.
Thanks, Tara. All right. Well, Mike, if you are here and having technical difficulties, please do let us know your feedback, your comments. Tara will be in touch with you to get that in writing, perhaps, or certainly you're welcome to come back next month and share what's on your mind. Okay. So in closing, just a couple of housekeeping pieces. Thanks for your flexibility on today's timed agenda. Of course, we know that certain things, require more or less time. So appreciate all of that flexibility. Our next OHPB meeting is on April 2nd. That will be via Zoom. A reminder that our health equity educational webinar, 2 sessions, March 19th and March 21, are available to us. Please take advantage of that opportunity. It takes a lot for people to put together this body of work for us. So I invite you and please ask that you engage it deeply. And then I think that's it to adjourn. Again, just a reminder to give feedback to myself, to Tara, in terms of the way the board meetings are running. Certainly come join us along with Kirsten at any of our leadership meetings. And with that, we are adjourned. Have a great afternoon. Bye-bye.